Namaste बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Associate Professor and HOD, Department of Practice of Medicine, in Faculty of Homeopathic Science at JYOTI VIDYAPEETH Women's University, Jaipur. In this series of lectures, we have been discussing about the various disorders related to the alimentary tract. Today, we are going to discuss about hyperaldosteronism, Addison's disease, and more diseases related to the adrenal system. So let's start with the hyperaldosteronism or Crohn's disease. Now, what is hyperaldosteronism? Hyperaldosteronism refers to the hypersecretion of the adrenal mineralocorticoid aldosterone. There is primary hyperaldosteronism that refers to the adrenal cause and can be due to an adrenal adenoma, bilateral adrenal hyperplasia, rarely glucocorticoid susceptible hyperaldosteronism. The secondary hyperaldosteronism is used when an extra-adrenal stimulus for renin secretion is present, as in renal artery stenosis, decompensated liver cirrhosis, and diuretic therapy. Now, the clinical features of Crohn's syndrome or the hyperaldosteronism. Most patients with primary hyperaldosteronism have difficulty to control hypertension, especially the diastolic hypertension. There is hypokalemia, headaches are common, and edema is characteristically absent unless congestive heart failure or renal disease is present. There is hypokalemia that is caused by urinary potassium losses. The other features includes muscle weakness, fatigue, polyuria. Potassium levels may be normal in mild primary hyperaldosteronism. Metabolic alkalosis is a typical feature. Now, the diagnosis. The diagnosis of hyperaldosteronism or Crohn's syndrome includes the treatment-resistant hypertension is associated with. Number one, the diagnosis. The diagnosis of hyperaldosteronism is a treatment-resistant hypertension that is associated with persistent hypokalemia, is a non-edematous patient who is not receiving potassium-wasting diuretics. In patient receiving potassium-wasting diuretics, the diuretics should be discontinued and the potassium supplements should be administered for 1 to 2 weeks. If hypokalemia persists after supplementation, the screening using a serum aldosterone when plasma renin activity should be performed. Differential diagnosis of hypertension and hypokalemia. The essential hypertension with vomiting and diarrhea. The diuretic therapy, oral contraceptives, and steroid therapy. In kidney disease, there is accelerated hypertension with renovascular hypertension and renin-secreting tumor. In adrenocortical dysfunction, there is primary hyperaldosteronism, Cushing syndrome, and ectopic ACTH syndrome. Exogenous administration of mineralocorticoid. Pseudoaldosteronism with excessive licorice ingestion. The treatment of hyperaldosteronism or the Crohn's syndrome includes removal of the adenoma, spironolactone, a potassium-sparing diuretic that is used before the surgery, sodium restriction, and amyloid, the sodium channel blocker is used, amiloride. The secondary hyperaldosteronism is treated with salt restriction and correction of the underlying cause. Next, we come to pheochromocytoma. What is adrenal pheochromocytoma? What are the clinical features, investigation, and management? Pheochromocytoma is a catecholamine-secreting tumor that arises from the chromaffin cells of sympathadrenal system. 90% are arising from the adrenal medulla, and extra adrenal pheochromocytoma is usually encountered intra-abdominally. The catecholamines are a group of similar hormones that are released into the bloodstream in response to physical or emotional stress. These are dopamine, epinephrine, and norepinephrine. The clinical features of pheochromocytoma includes hypertension. The hypertension can be paroxysmal or sustained. The paroxysmal hypertension arises suddenly, lasting for minutes or hours, that is brought on by emotional strain or palpation of the abdomen. There is sudden change in the posture, such as lying on one or the other side of the bed at night. The symptoms of pheochromocytoma includes headache, sweating, palpitation, pallor, nausea, tremors, weakness, anxiety, epigastric pain, chest pain, dyspnea, and constipation. Sustained hypertension. Tumor secreting adrenaline or noradrenaline constantly causing persistent hypertension. The diagnosis is by increased free catecholamines or metabolites in the urine, CT or MRI for tumor of the abdomen. The treatment of pheochromocytoma includes removal of the surgical removal of the tumor, preoperative therapy to minimize the risk of precipitous hypertension during surgery, and beta blockers before the surgery. Next, we come to the Addison's disease. Addison's disease is basically a disease of the adrenal gland. We have discussed about Cushing syndrome, in which there was excessive secretion of cortisol. And the Addison's disease is exactly opposite of the Cushing syndrome. It occurs when more than 90% of the adrenal tissue are destroyed. The causes are polyglandular autoimmune syndromes, tuberculosis, other granulomatous disorders, which include histoplasmosis, coccygodymycosis, cryptococcus, and sarcoidosis, bilateral adrenalectomy, bilateral tumor metastasis, bilateral hemorrhage, cytomegalovirus, HIV, amyloidosis, and congenital diseases. The pathogenesis of Addison's disease includes increased secretion of ACTH. The lowered cortisol level causes increased ACTH production, with ACTH acts directly on the melanocytes, causing pigmentation of the skin and hair. There is deficiency of adrenal cortical secretions. Number one, aldosterone, second is androgen, and the third one is cortisol. So there is deficiency in the secretions. So aldosterone deficiency produces hypotension, decreased sodium, potassium retention, and marked acidosis. Deficiency of androgen causes loss of pubic and axillary hairs in females, loss of muscle mass, weakness, and loss of libido. Deficiency of cortisol produces weakness, anorexia, nausea, vomiting, hypoglycemia, and inadequate water diuresis. The clinical features of Addison's disease includes insidious onset, pigmentation of the skin and mucous membrane, bluish-blackish discoloration, brownish patches or streaks on the lips, gums, inside of the cheeks, and posterior aspect of the palate. There is hyperpigmentation of the extensive surface, pressure points, and the scars. Example, face, neck, dorsum of hands and knuckles, etc. The areas of vitiligo and leukodermic type of pigmentation. In case of Addison's disease, there are various gastrointestinal symptoms, which includes nausea and vomiting, salt craving, and abdominal pain. The cardiovascular features include postural hypotension, faintness, and heart sound are feeble. The muscular system includes muscular weakness and wasting, sometimes cramps. The mental and nervous symptoms includes lassitude and muscle weakness, loss of memory, drowsiness, period of irritability, and insomnia. The genital system impotence and amenorrhea is present. The miscellaneous feature includes subnormal temperature, loss of body hairs and axillary and pubic hairs in females. The other autoimmune diseases includes vitiligo, thyroiditis, pernicious anemia, and insulin-dependent diabetes mellitus, etc. Now, the clinical features of Addison's disease includes fatigue, weakness, anorexia, nausea, vomiting, weight loss, abdominal pain, cutaneous and muscle mucosal pigmentation, salt craving, hypotension, especially orthostatic, and occasional hypoglycemia. There is serum sodium is reduced and serum potassium is increased, extracellular fluid depletion, and accentuates hypotension. Secondary adrenocortical insufficiency occurs due to the pituitary or hypothalamic disease, such as tumors, infarctions, trauma, granuloma, or necrosis. The signs and symptoms are identical to that of the Addison's disease, except for the absence of pigmentation. The features are associated with hypotension are unusual since aldosterone secretion is maintained despite of absence of ACTH. The diagnosis of Addison's disease can be done by plasma cortisol level that is measured at 9 a.m. with less than 50 nanomole per liter confirms the diagnosis. Plasma ACTH levels more than 80 nanogram per liter, radiography of abdomen that reveals calcification, adrenal tuberculosis disease. Chest shows tuberculous lesions or malignancy, and adrenal autoantibodies that are detected in 55% of the patient. In the differential diagnosis, there is Simmons or Sheehan's disease, disease with aesthesias, anorexia nervosa, and other causes of pigmentation that includes pellagra, freckles, birthmarks, nevi, etc. The management of Addison's disease is done by administration of glucocorticoid like cortisone, aldosterone substitution, and salt is given additionally 3 to 6 grams of salt intake daily. So this was all about today's lecture. We have discussed about the Conn syndrome, we have discussed about pheochromocytoma, and we have discussed about Addison's disease. So I hope you must have understood the session properly. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.